Good morning. Welcome to Department of Medicine Round Rounds. Glad to see you this morning. Every year about this time of the year, we celebrate the life, career, and accomplishments of Dr. George William Pedigo Jr., who was a beloved educator and physician in Kentucky. In fact, he was from Glasgow, Kentucky. He received his medical degree in 1938 from the University of Louisville, and after a short stint elsewhere and also service in U.S. Army, he came back and joined the faculty in 1946. He was a former governor of the American College of Physicians and life member of the University of Louisville Board of Overseers, promoted to emeritus professor in 1981, and received the Kentucky's first laureate award, which is quite a prestigious award in the state, and was made an ACP master in 1991. He was very well known by his colleagues, and there's still people who tell me about him and his ability to engage patients and students alike. And because of this, Mr. and Mrs. Robert Hooke established an endowment in 1988 so that we could have this celebration every year. So in his honor, we go around the country trying to find people who have distinguished themselves as strong clinicians, strong educators, scholars, researchers, but in essence, role models and leaders in academic medicine. And today is no exception. So it gives me great pleasure to introduce Dr. Michael-Iannuzzi, who will be our 23rd Pedigo lecturer. Dr. Iannuzzi is Edward Reifenstein Professor of Medicine and Chairman of the Department of Medicine at Upstate Medical University in Syracuse, New York. In 1979, he finished his MD education at the University of Michigan and stayed there as an intern, as a resident, and then as a chief resident, but then later on moved to the University of Colorado. At that time, that was today arguably the premier place to train in pulmonary critical care medicine. And he finished there in 1986 after his clinical training and some research at the Whip-Warring Institute, returned back to Ann Arbor at the University of Michigan in, I think around 1986-87, to become instructor, then assistant professor. Did some time at Henry Ford in Detroit as a senior staff there until 2002. Had a short stint as professor at Case Western University from until 2003 or so. And then he was lured away to New York, closer to home, where he became the division director and established a strong division of pulmonary critical care at Mount Sinai. And he was there until 2008. I had the pleasure to visit him there, and he had done a terrific job. And I guess 2 years ago, Syracuse called, knocked on the door, and lured him away, and have been very pleased for all the things that he has done there and just a short time and changing the way the Department of Medicine works and educational activities and so forth. Now, as you will see in his lecture today about sarcoidosis, Mike is a very good clinician and educator. You get some glimpse of that. But Mike really made his mark in research very early on when he was part of the group who discovered the cystic fibrosis gene back in the late 1980s. And so he's been involved quite a bit in cystic fibrosis research since then. He's won a number of awards for those efforts. But I know him best because of his work in sarcoidosis. And for many years, and perhaps even today, we still consider him one of the premier investigators in the area of sarcoidosis, which there are not a lot of people investigating. It still remains a mystery, as the title of his lecture presents today. He had a number of NIH grants investigating the genetics of sarcoidosis. He's been involved in multiple NIH study sections. He was the chair of the American Lung Association study section. I'm pleased to have him as part of the ATS Scientific Advisory Committee and study section. He's published over 100 publications and books, and he's just simply very well known in the community for being a strong academician, loves students and education. I think you'll see that today. And so without further delays, it is my pleasure to introduce my friend, your Pedigo lecturer, Dr. Mike-Iannuzzi. Mike?
Well, it's definitely an honor to be here. I'm very grateful for the invitation. Let's see. Here, this is what I'm using. think we can agree that sarcoidosis is in the top 10 list of mysterious diseases. And the reason we can say that is we do not know why patients get these granulomas, or why some patients who present with sarcoidosis then go on to have a spontaneous remission, while others then go on to have fibrosis. And you can see here in this x-ray with the fibrosis in the upper lung fields, highly retracted up, and tenting of the diaphragm. But yet, while it's still a mystery, progress has been made. Each month there are at least 60 manuscripts dealing with sarcoidosis. There's been hundreds of unusual cases reported. Newer diagnostic techniques have been reported using endobronchial ultrasound now to diagnose sarcoidosis. We've learned of new aspects of sarcoidosis, alpha interferon-induced sarcoidosis, alpha interferon being used to treat hepatitis C, and most recently, alpha interferon used to treat metastatic melanoma has now been reported also to result in sarcoidosis. And we've learned that there's been an outbreak of sarcoidosis cases after the World Trade Center disaster. Also, recently, there's been a large, well-controlled design study to look at the etiology of sarcoidosis, and we'll come back to that. There's been a proteomic search for the etiologic cause of sarcoidosis, and 3 genome scans have been reported in sarcoidosis. So what we're going to do in the next 30 minutes or so is put some of these puzzle pieces together and see what kind of picture has evolved in our understanding of sarcoidosis. My talk is going to be divided into 4 parts. I'm going to start out talking about the history of sarcoidosis. I'm going to spend most of the time discussing with you common pitfalls, things that I've learned over the last 20 years in dealing with sarcoidosis patients. I'm going to briefly review immunopathogenesis and tell you an update on the genetics of sarcoidosis. So it's Sir Jonathan Hutchinson who is credited with giving the first case description of sarcoidosis. He had a 58-year-old co-worker present to him in 1869 with these progressive purple plaques on his hands. That patient died 6 years later of kidney disease, probably related to hypercalcemia and nephrocalcinosis. And he reported this as a case of livid papillary psoriasis in his textbook, Illustrations of Clinical Surgery of 1877. Livid comes from lividus for lead-colored. But it was Caesar Beck in 1899 who coined the term sarcoidosis. Caesar Beck from Finland was benefiting from technologic developments. Hematoxylin had been discovered in 1865, or borrowed from the textile industry. The dye was used to color textiles and isolated from the logwood trees. But he had one other additional advantage over Hutchinson, in that he had a patient who was willing to participate in a study. He biopsied this patient, did a punch biopsy, and then in looking at the histology, he reported that it consisted of epithelioid cells with large pale nuclei and also a few giant cells. He thought that this resembled sarcoma, so he called this sarcoid, or sarcoma-like. Sarcomos comes from the word sarcamos, for flesh, and that's where we get the word sarcasm, cut to the flesh. So that is where the word sarcoidosis comes from, which is essentially a meaningless word and confuses our patients when we use it. It then took the discovery of x-rays to learn that it was more than just a skin disease, and 30 years later, when this report came out in 1915, sarcoidosis with involvement of the inner organs. So we talked a bit about the history of sarcoidosis. It was Sir Jonathan Hutchinson credited with describing the first case, a case of livid papillary psoriasis. It was Caesar Beck who coined the term sarcoidosis, thinking it resembled sarcoma because of the collection of epithelioid cells. It took the discovery of X-ray and 30 years to realize it was a multi-system disease. And let's turn to that for a moment. Sarcoidosis is a fun disease to talk about and learn about because it is a multi-organ disease. These are pictures from the patients that I've taken care of over the years. This shows cobblestoning, airway involvement, neurosarcoidosis, spinal cord involvement, unfortunately lupus pernio. This is a gallium scan showing the classic lambda panda sign, lacrimal gland enlargement, optic nerve tract involvement, fibrotic lung disease, anterior uveitis, cardiac involvement, and bone involvement. A disease worthy of us discussing in any grand round because it has so many different manifestations. So with that, let's focus on common pitfalls. And I'm just going to select 5 organs. We're going to talk about the pitfalls involving skin manifestations, ocular, heart, neuro, and lung. So it's my goal that we avoid these pitfalls. So let's go through some of this. And I want to start out with a story, The Adventure of the Blanched Soldier. This is a Sherlock Holmes episode published in 1903. I remind students and residents to read Sherlock Holmes because there's no better way to learn about observation skills, things that we should really work at strengthening. In fact, in that Adventure of the Blanched Soldier, Sherlock Holmes says, "It is my habit to sit with my back to the window and to place my visitors in the opposite chair where the light falls full upon them," reminding us that when we do a physical examination, we should have good lighting. And in fact, as maybe many of you already know, Sherlock Holmes was modeled after Arthur Conan Doyle's mentor and teacher, Dr. Joseph Bell, and there's so many characteristics about Dr. Joseph Bell built into Sherlock Holmes, even the way he looks. And this came when Doyle did his clerkship at the Edinburgh Infirmary in 1877. But anyway, back to the story. A client went to Sherlock Holmes, and his friend had disappeared. And he went to the family, and the family wouldn't give him any information about what happened to him. So he was thinking that something really bad happened. And it was the family was hiding the fact that their son had this skin affliction, leprosy, and they wanted to hide that from anyone else. And in that episode, Holmes wrote, "I was finishing this little analysis of the case when the door was opened and the austere figure of the great dermatologist was ushered in. 'It is often my lot to bring ill tidings and seldom good,' said he. 'This occasion is the more welcome. It's not leprosy.' 'What?' 'A well-marked case of pseudoleprosy or ichthyosis, a scale-like affection of the skin, unsightly, obstinate, but possibly curably and certainly non-infective.'" So, ichthyosis comes from the Greek fish, the scaling abnormalities, and this is ichthyotic sarcoid of 2 patients of mine with this affliction. So, what's the point of telling you the story? I want you to remember that skin lesions in sarcoidosis vary and are often misdiagnosed. In fact, I came across this statement in a textbook of dermatology that says from 10% to 100% of sarcoidosis patients have skin manifestations, depending on whether the internist or the dermatologist does the exam. And that relates to the fact that the skin manifestations vary so much. So let's just go through some pictures of what these things look like. The most common is maculopapular, and it typically occurs around the nose, the mouth. Can be the scaling lesions up in the corner of the eye. They can be more plaque-like, again occurring about the face, around periorbital. This is the lips involvement. It can be plaque-like, as in here. It can lead to hypopigmentation and hyperpigmentation. It can be singly. This patient had complete heart block, and we were not sure what the cause was, a non-ischemic heart block. The chest x-ray was normal. I found this, biopsied it, and diagnosed cardiac sarcoidosis. Can be single or in crops. Can cause alopecia and even have plaques in the scalp. Unfortunately, it can result in lupus pernio. Lupus pernio may also involve the cheeks and portends more chronic disease. Now, there are lookalikes. There are lookalikes that I just want to make sure you don't confuse with sarcoidosis. This is not acne, but that is a sarcoid lesion. This is not psoriasis, this is sarcoidosis at the nape of the neck. This is not xanthelasma. These are the waxy nodules of sarcoidosis. This is xanthelasma. Now, just to make sure you're not confused, these are nodules on the shins. This is not erythema nodosum. These are granulomatous nodules on the shins. Erythema nodosum, coming from the Greek for eurythos, red, are knots. They're hot, red, shiny, tender nodules. Now, they last about 3 weeks and they can recur. Erythema nodosum is septal paniculitis. So you do not need, and you should not, biopsy erythema nodosum in the hopes of clarifying the diagnosis, because you'll get back septal paniculitis consistent with erythema nodosum. So you don't need pathology, and it doesn't confirm the diagnosis of sarcoidosis. You should be reminded that erythema nodosum is associated with Lefgren's syndrome, and I want you to know that we more recently learned that the manifestations of Lefgren's syndrome are different in women than men. Erythema nodosum is more common in women and less common in men, and the polyarthralgias is more common in men and less common in women. Lefgren's syndrome is also associated with uveitis, hyaluradenopathy, fever, and fatigue, and it portends a good outcome, as opposed to lupus pernio, which portends a poor outcome. Sarcoidosis has a peculiar tendency to light up scars and tattoos. Those reddish areas on tattoos can often be infiltration of granulomatous inflammation. So when you're looking for a place to biopsy, discuss with your patients what their tattoos, have they changed at all, have they become more raised. And we sure know that tattoos are like hit in this country as an epidemic. So I started out with the story of Sherlock Holmes to help you remember that skin lesions are varied. Maculopapular is the most common. Don't get confused with other lesions. It's a very rich source of material to biopsy and confirm the diagnosis. Now let's move from skin to ocular manifestations. 25% have ocular involvement. And you must remember that ocular involvement may precede other organs by decades. So a patient can have uveitis in their 20s and come back in their 50s and 60s with other manifestations of sarcoidosis. Uvea comes from the Latin uva, for grape, and the uvea is that layer between the sclera and the retina, the vascular coat. It goes forward, forms the ciliary body and the iris. So when the vascular coat in the posterior aspect of the globe is involved, it's choroiditis. When it's the ciliary body, it's cyclitis. And when the iris is involved, it's iritis. And when both the iris and the ciliary body, iridocyclitis. Acute anterior uveitis presents with acute pain, redness, photophobia, blurred visions, and excessive tearing. Chronic anterior uveitis, you need to remember, and as opposed to acute, is insidious, very few symptoms. It is because chronic anterior uveitis is more common than acute that we need to do routine slit lamp exams in anyone with sarcoidosis, and we're looking for these waxy precipitates of inflammatory cells in the anterior chamber. Also a good fundoscopic examination. You look for granulomatous infiltration in the choroid. And then if there's any suggestion, fluorescein angiography is the next technique of choice to look for leaking of the vessels where the granulomas infiltrate. The conjunctiva often have granulomas in them and are a rich source for a biopsy. So the point here is that complete ophthalmologic examination should be routine in anyone you're considering the diagnosis of sarcoidosis. So we went through skin and ocular. Let's turn to cardiac sarcoid. Unfortunately, a lot of cardiac sarcoid literature is found in forensic medicine, and every once in a while I get a phone call from a relative, a wife or a husband, where someone just dropped dead at work and they're only 20 or 30. And at autopsy they're found to have sarcoid granulomas. Well, let's look at where the granulomas infiltrate the heart. Most commonly it's the left ventricular free wall, followed by the high septum. Next, much less frequent, is the free right ventricular wall, and then finally the right atrium. So the reason biopsies aren't helpful is where do the cardiologists like to do their biopsies? On the right side of the heart, just where the granulomas don't tend to be. Plus, they tend to be patchy. And if you look at that distribution of where the granulomas go, it's no mystery then why conduction abnormalities and arrhythmias occur in cardiac involvement, and why there's left ventricular dysfunction, where most of the granulomas settle out. Best way to detect cardiac sarcoid is not known. So let me share with you some thinking. Well, what tests are available? Well, there's gallium scans, but they're not too sensitive. Thallium scans, well, I find them useful to help rule out ischemic heart disease, and you might be lucky in that you see the perfusion abnormality that gets better with exercise. Better yet is magnetic resonance with gadolinium. This is becoming a fairly useful technique. But I think probably the most sensitive is cardiac PET. This just came out in August. It was interesting and unfortunate. This patient had a cardiac PET to evaluate something, arrhythmias, and he dropped dead 2 weeks later. So here's his autopsy, and they correlated the autopsy findings with his PET scan 2 weeks before. And this is really the first opportunity to see how good the PET scan is. The more yellow it is, the more active the disease, and you can see it actually follows pretty darn good what's going on in the heart. Unfortunately, I often have to fight with insurance companies to get cardiac PETs approved because they have such limited indications, and sarcoid's not on the list. But I usually end up having to go through the whole routine of writing letters and getting other tests first. I'd like you to remember this. Cardiac sarcoidosis very often occurs in the absence of disease elsewhere. You should never say a patient doesn't have cardiac sarcoid because their chest x-ray is normal. You must consider cardiac sarcoidosis in any non-ischemic cardiomyopathy. So let me share with you an approach to cardiac sarcoid. It's my approach. I can't give you a lot of data to support this, but I'll give you my thinking. We use symptoms to screen. Probably the most serious symptom to consider are palpitations. Every patient, no matter how young they are, gets an EKG. We look for first-degree blocks or any blocks. If there's any symptoms at all that suggest cardiac origin, the patient gets a cardiac event monitoring, a stress echocardiogram, and then consideration for either a MRI or PET scan. Electrophysiologic studies are often called for, but you should recognize that they have a sensitivity of only 82%, which means that your patient can still drop dead after a negative EPS study. You just keep that in the back of your mind. It's not a 100% test. So we've discussed skin, ocular, and cardiac manifestations. I'd like to now jump ahead to neurosarcoidosis. This is my daughter's dog, Oliver. My daughter got him as a sweet 16th birthday present. She's in college. I am now a proud dog owner. And I love him. Well, anyway, neurosarcoidosis can involve any cranial nerve. Most commonly, it involves 7 and 2, followed by 2. Cranial nerve 7 is usually sudden and resolves spontaneously. The optic nerve is involved next. Pituitary gland can be involved, and most commonly when it's involved results in diabetes insipidus with the posterior pituitary involved. But all hormone abnormalities have been described in sarcoidosis. The hypothalamus can be involved, resulting in pituitary insufficiency. encephalopathy, and the dreaded spinal cord involvement, which can result in paraplegias, hemiplegias, and unfortunately even quadriplegias. Like cardiac sarcoidosis, neurosarcoidosis may be the only manifestation. And again, a negative X-ray doesn't rule out neurosarcoidosis. And in that regard, we've learned that PET scanning often demonstrates occult disease. And in the case of cardiac sarcoid and a neurosarcoid, when you entertain the diagnosis, PET scanning may give you a place to biopsy to help diagnose it. Certainly neurosarcoidosis, we try to avoid biopsying the nervous tissue, so PET scanning may has a greater role. I told you we're limited in cardiac biopsy because of the patchy nature of the disease, and that involves the left side of the heart. So PET scan sometimes helps you. I'm going to spend a little time on cardiac, lung. What is that? What are those? Lungs. Sarcoidosis is the prototypic restrictive lung disease. But here's a little caveat. As sarcoidosis causes restriction from infiltration in the lungs, causing stiffer lungs and increased elastic recoil, then you treat the patient with, say, prednisone, and the infiltration improves, you uncover obstructive lung disease. Because of the increased elastic recoil, flows are increased above normal. And sometimes you don't recognize the concurrent obstructive lung disease until you start treating the infiltration. Pulmonary hypertension is often found in sarcoidosis, up to 23% of patients at rest and 43% with exertion. And while granulomatous vasculitis may result in pulmonary hypertension, far more common is pulmonary hypertension associated with destructive lung disease. We have not yet defined the prognosis of pulmonary hypertension in sarcoidosis, or have we defined the effective treatment. There was this paper out of Johns Hopkins. Retta Gurgis was my fellow at Henry Ford. I got him interested in sarcoid when he was with me at Henry Ford, and he's associate professor now at Johns Hopkins. And in their chest paper, they reported that treating the pulmonary hypertension in sarcoid resulted in improvement in New York Heart Association classification of heart failure, and that treating pulmonary hypertension and sarcoidosis resulted in improvement of the 6-minute walk test. Small study, but a glimpse that perhaps we need to get more studies done on this. So we reviewed common clinical pitfalls in 5 organ systems: skin, ocular, heart, neuro, and lungs. Let me just say one word about diagnosis. In the absence of Lefgren syndrome, diagnosing sarcoidosis without histologic support puts you out on a limb. So I'm a strong proponent of histologic confirmation of the disease and not making the diagnosis based on chest X-ray appearance. Mediastinoscopy, usually not necessary. I cry whenever I see a patient who comes to me after mediastinoscopy that was unnecessary, because bronchoscopy has such a great diagnostic yield. And now with endobronchial ultrasound, there's very little reason to send a patient for mediastinoscopy. No reason for them to have a scar and have a chest tube. Once in a while it happens, but it's got to be minimally. There's a lot of stuff out there about treatment, and here's why. Remember Caesar Beck's patient, the patient who agreed to get his skin biopsy? This was him in 1899 when Caesar Beck coined the term sarcoidosis. Here he is in 1940. Guess what? He wasn't treated. So here's our problem whenever you assess treatment in sarcoidosis. Why case series don't work. It's a disease with spontaneous resolution. Unless you really do an excellent randomized control, double-blind, whatever, you get down the wrong path. There are 5 indications for steroids. Only 5 indications for steroids. Cardiac, neuro, decline in any organ system. If the function is declining, that's an indication for treatment. Terrible symptoms. I can't get out of bed. And hypercalcemia to prevent nephrocalcinosis and renal insufficiency. There's just 5 indications for steroids. Treatment, burst and taper, not a good idea. Why? Because those granulomas don't disappear very quickly. So when you decide, when you have one of those 5 indications for treatment, you treat for 6 to 9 months. Use of alternative agents in sarcoidosis are at this point anecdotal. And you'll find, well, I've had patients respond to azathioprine, I've had a patient respond to Celsep. Oh, maybe methotrexate is good. Just case series. You have to be cautious in interpreting these reports. Doesn't mean you don't try, but you have to understand the basis for some recommendations. So, sarcoidosis is one of the top 10 mysterious diseases. What do we know about the cause of sarcoidosis? I've discussed the common clinical pitfalls and I've talked about treatment, so what can I say about the cause of sarcoidosis? Well, if you go to Google and you put in pine and sarcoidosis, you get 64,300 hits. So where did that come from? Well, it went like this. There's these pine trees down at the Atlantic southeast coast, and geez, there was a lot of sarcoid over there. Oh, looks just like the same. You go down there, and Jesse had me visit Emory. He's always inviting me. What a great friend, really. And I saw, Jesse down there scraping the stuff off his car. It's all this pine tree pollens, and he's exposed to it when he golfs. So they're down there. But it all came from Cummings in 1958 at the Atlanta VA. This was a picture from the Atlanta VA when it existed then. And what these 2 guys said was they took the pine pollen and they stained it for acid fast, and geez, it's acid fast positive. And they then took a mouse and sensitized it with the pine pollen and found granulomas. So they said, well, pine pollen's down there, sarcoid's down there, it's all over the place, it's acid fast positive, you sensitize mice, you get granulomas, ergo, pine causes sarcoidosis. Well, back at the Fitzsimmons Army Hospital, there was Dr. Joel Rickard. And he contacted Cummings and he said, look, send me that stuff. I put him in gelatin capsules. He loaded up 720 milligrams of loblolly pine pollen, and he took 30 doses from March 7th to May 9th, 1959. This was a letter to the editor to the Blue Journal in 1959. And this is what he reported in that letter. He had a tendency towards loose stools. His PPD remained positive. He was a lung doc, and he had been exposed earlier. But his chest x-ray remained negative. He reasoned that if pine pollen was the cause, it would impact in the nose, and you would swallow it, it wouldn't make it down into the alveolar space, or the respiratory particle size. It was too big. So that's why he reasoned if I ingested it, if it causes sarcoid, something will happen. So I actually found him in 1999. He was retired. He lives in the suburbs of San Francisco. And he told me he was doing well. His chest x-ray still was negative, and he hasn't developed any problems. Now, the U.S. government took a different approach. We had a $10 million etiologic study. There were 10 centers involved. We found 720 cases and 720 controls. It was the largest well-controlled, geographically matched study ever performed to try to get at the etiologic cause of sarcoid. And we found no single culprit. What we did find was there was an association with exposure to molds and smelly molds. Now, the p-values were absolutely great. The effects were really quite modest. Now, the mold mildew muscular exposure has been borne out in other studies, and we have to believe it. Maybe it's suggesting that there's some bioaerosols. But Dave Moeller at Johns Hopkins used the the most sophisticated mass spec available and identified Mycobacteria catalase peroxidase protein in sarcoid tissues. 55% of sarcoidosis patients have evidence of Mycobacteria catalase peroxidase, and he's doing a lot of research to try to prove that this is a significant cause of sarcoidosis. He keeps coming back with more and more data supporting this, and it's very exciting, and perhaps he's found an important etiologic event. So let's now turn to the immunopathogenesis. Well, the key in understanding it has got to be to understand what makes granulomas. So granulomas are there to phagocytize, to eat the pathogen, to keep it there. Well, I got to tell you, I'm a little bit obsessive about sarcoidosis and granulomas. I see granulomas everywhere I look. I could be driving down the road. You just see this formation. I can't even stop even looking up in the sky. But this is the way it goes. The way I view it. Genetic predisposition is a prime responsibility. It requires an environmental risk, whether that be a bioaerosol or Mycobacterium catalase. Somehow the CD4 positive T cells are importantly involved. Cytokine dysregulation occurs, and then granulomas accumulate. But the activation of CD4 positive cells, cytokine dysregulation, and granuloma accumulation are also involved with genetic components, resulting in change in phenotype. And some people get fibrosis, and also likely under genetic involvement. About 1% of first-degree relatives of sarcoidosis patients also have sarcoidosis. First-degree relatives, children, sibs, parents. But that means you'd have to screen 100 patients to find 100 relatives to find the other one who has it. So we don't recommend screening families, but sarcoidosis incidence is anywhere from 11 to 100 per 100,000 in whites to 35 per 100,000 in blacks. So the risk to a family member is much greater than the general population. So there's significant familial risk. The genome scans I've told you about have delivered BTLN2, butyrophilin-like protein 2, and this has been confirmed by several studies, has been associated with sarcoidosis. It is a negative co-stimulatory molecule. It's in that immune synapse. You know, the immune synapse is a lot like the printer cable, the port on your printer. There's all these pins, and depending on which pins are delivering the signal to the printer to tell, oh yeah, well, back and forth between the computer and the printer, yeah, there's paper in it, the power's on, there's ink. That's the same thing that goes on in the immune synapse, back and forth between the antigen-presenting cell and the T cell. And BTLN2 is dysfunctional in sarcoidosis. More recently, a genome-wide association study identified an exon 11, also confirmed in other studies. An exon are calcium-dependent phospholipid binding proteins. The expression is widespread, so it's in lung tissue, spleen, liver, GI tract. And its exact role is not well defined yet, but it appears to be involved in apoptosis as one mechanism that might be involved in sarcoidosis. I'd now like to just tell you a little bit about work in progress with my colleagues, Ben Rubicki at Henry Ford and Courtney Montgomery in Oklahoma. We've just completed a GWAS study in African Americans, and Courtney is in the process of writing that up, so it'll be submitted pretty quickly, reporting our results. This is one of the pictures. We found 6 significant regions associated with sarcoidosis. We did this GWAS, Genome-Wide Association study, in 1,271 cases and 1,465 controls. We found 78 suggestive regions, and we're going in for repeat funding to try to find map these regions. I have to talk a bit about the Kavaim-Sitzbach reaction, having been at Mount Sinai. Kavine first described it in 1941 using lymph nodes, and Sitzbach reported it in 54 using spleens, patient spleens. And Sitzbach went on to demonstrate its sensitivity of 80% and its specificity has only a 1% false positive rate. And you put you take a patient's spleen, you throw it in a blender, and then you wash it in phosphate buffered saline, and then you make a membrane suspension. I made a few batches up while I was at Mount Sinai. Using spleens that were stored from before 1960. You put it on a skin just like PPD, and you come back 4 weeks later and you biopsy the site and you find granulomas. It's phenomenal. It reproduces the disease. So the key to understanding sarcoid has got to be in that Kavine test. It's got to be in that reagent in those membrane fractions. It is the single most important piece of the puzzle of understanding sarcoidosis. So, while I was at Mount Sinai, I got some patient volunteers who had just been diagnosed with sarcoid. I put 4 Kavine tests on them, and I biopsied it at week 1, 2, 3, 4, made RNA, and we're presently doing the microarray analysis to see what genes get activated during the formation of a human granuloma in a sarcoid granuloma model. I think this is going to be fascinating. I'm really excited to look at it, to look at the results, and hopefully it'll give us some understanding of exactly what goes on with gene expression during the formation of granulomas. Another aspect that we've got going on is we've collected, when I was at Henry Ford, we've collected 200 BALs on patients, non-smokers, untreated at the time of diagnosis, hard to come by, untreated non-smokers. Then made RNA and stored it, didn't touch it, waited 5 years, phenotyped the patients who we still had all the information on. And from that, I was able to identify 16 patients who really progressed from the time we diagnosed them forward, and 11 patients who clearly started out with our sarcoidosis and resolved. And it took a couple of hundred BALs to get such a pure sample. But I believe if you're going to do a microarray experiment and you're going to compare one group to another, it's all about how pure the groups are. And we're in the presence of analyzing this microarray data. So we've talked about the history of sarcoidosis, the first case report. We've talked about Caesar Beck, multi-organ disease. We've talked about Sherlock Holmes, the adventure of the Bland soldier, to tell you that the skin lesions are so varied. And we've talked about Lefkin syndrome having a good outcome, and lupus perennial having chronic sarcoid, and the importance of ocular evaluation in sarcoidosis to look for chronic anterior uveitis, which is insidious and more common than acute. We've talked about cardiac sarcoid can occur in the absence of disease elsewhere. Patients can drop dead. The cardiac PET looks like the best test to use. Neurosarcoidosis with cranial nerves most commonly involved, 7 followed by 2. This devastating abnormalities can occur. Neurosarcoid can be the only manifestation of sarcoidosis in 25% of patients with neurosarcoid. We talk about restriction and obstruction in the lung disease. Problem with evaluating treatment studies is that without patients can resolve spontaneously, so the studies have to be carefully designed. I talked about where we got this notion that pine pollen can cause sarcoidosis with Dr. Rickert eating the stuff. And we've talked about the ACCESS study, the very well-designed, large 10 multi-center study that came up with exposure to molds and musty odors. We've talked a bit about granulomas and the pathophysiology, a broad look of sarcoidosis. That BTLN2 has been a gene discovered in genome-wide association studies, and an Annexin 11 is the next a gene that was found and has been confirmed. I've told you about our own research work in progress. looking at the Combine test gene expression pattern over the 4 weeks that it takes to develop a positive test. And perhaps sarcoidosis is not sarcoidosis, but sarcoidoses. So meaning more than one cause resulting in these different manifestations. Well, thank you for your attention. I'll be delighted to hear your comments or answer any questions.
Dr. Iannuzzi, thank you very much for that terrific overview. I wanted to ask you one question before I ask the audience to participate. There are many countries where sarcoidosis is very uncommon. You go to South America and other places, and people say, well, we don't see sarcoidosis. And I'm told that as those countries develop and they get control of their tuberculosis, sarcoidosis starts to creep up. Can you tell us a little bit about that?
Yes.
What do you think is going on?
I think that's absolutely true. I think in countries where tuberculosis is rampant, patients will present with enlarged mediastinal lymph nodes, and they get diagnosed empirically as tuberculosis. And just as you said, as tuberculosis comes under control, the incidence of sarcoidosis is increasing. And for example, it used to be thought that sarcoidosis was rare in the Asian Indian population, but as TB gets under better control, sarcoidosis diagnosis increases.
Questions?
Yes, sir.
So I noticed that you didn't mention antibiotic therapy. Yet there are, at least for cutaneous sarcoidosis, there's no good studies, but there are suggestions that minocycline and doxycycline are effective. If indeed your premise that there may be a mycobacterium involved, why not try things like erythromycin or other agents such as that?
Can you repeat the question?
Yes, the question was, what about the use of antibiotics? There's been a case series reported of using doxycycline, particularly for skin sarcoidosis. And since Dave Moeller has identified the Mycobacterium catalase protein, why not consider a macrolide antibiotic to treat sarcoidosis? And I think two things should happen. One is confirming that any individual patient may have had Mycobacterium catalase, and Dave Moeller is doing just that, developing tests to determine which patients may have strong evidence that they got infected with or have the Mycobacterium catalase protein. And then once you identify that, then you could do a controlled study of, the person has been exposed to that particular bug, then try in those patients the use of antibiotic in a very careful, again, because of spontaneous remission, you'd have to really do a randomized controlled trial to know if the drug works. So for doxycycline, there is no yet well-designed study to demonstrate it's effective. It's a harmless drug, supposedly, and people occasionally empirically try it, but there is no support, logical support to do it other than a case series. Yes, Don.
Mike, just a quick question. If you look at the familial cases, is the phenotype the same? Is there a clue there for etiology?
Excellent question. The question is, since there's familial sarcoidosis, is there concordance for the presentation or the signs and symptoms? And what we found was very modest concordance among siblings for liver and ocular disease and anemia, but not for anything else. Yes?
I was kind of intrigued by the proposition that steroids actually get discontinued in the patients in which they get started. Because what we see is that we start steroids in people who are already most affected. Those patients tend to progress. And it seems clinically very unlikely that the primary care doctor with my patients would actually ever come off the steroids. Can you talk a little about that?
So sarcoidosis is, the question was, It seems that there are many patients who don't come off of steroids and need them chronically. Sarcoid is characterized by recurrences, and the disease may last for decades. So the key is to have a clear indication for starting them. So again, I gave those 5 clear indications: progressive decline in an organ system, terrible symptoms, cardiac neuro, and hypercalcemia. So if you had a clear indication to start, generally you need to treat for 6 to 9 months to even a year before you think about tapering them off. We often taper patients off the prednisone to find out they need to go back on. And this may happen 2, 3, 4 times in their lifetimes. So consideration for how the patient is tolerating the prednisone and whether or not a steroid-sparing agent can be added, such as methotrexate, is certainly something to consider. The disease is characterized by recurrences, so you need to work to get the patient to the lowest dose and not do burst and tapers. So my approach is to begin with 40 milligrams a day, taper 5 milligrams every 2 weeks until 20, 25 milligrams, leave them at 20 to 25 milligrams for several months, and then generally when they recur at around 10 milligrams. So that's kind of like the range of prednisone. I try not to go down to 10. It's a mistake, except for neurosarcoid, to start with 60 or 80 milligrams of prednisone. It's totally unnecessary, and it only causes a lot more side effects without much improvement. Ralph and I were talking about this last night. It is likely there's a subsegment of patients, a subgroup of patients whose fibrotic disease moves parallel to whatever the granulomas are doing, and it isn't that granulomas lead to fibrosis, and if you get rid of the granulomas, you prevent fibrosis. We all have the experience that something else in some groups seems that the fibrosis pathway is independent of what's going on. You give the prednisone, you do improve granulomas, you do improve the symptoms related to the granulomas, but they can go on and still fibrose. And like idiopathic pulmonary fibrosis or UIP, we don't have an effective drug to prevent or treat fibrosis. Yes? For the most part, patients will show you their disease in the first 3 years of illness. It is very unusual to say that you presented with skin and hyaluradenopathy and some polyarthralgias, and that's all you had for 3 years, and 10 years later die of cardiac sarcoid. That would be very unusual. Most patients show you what they're going to have problems with in the first 3 years of illness. Let me just go back in terms of the prednisone. When you take a patient off of prednisone, if they have no evidence of disease activity for 6 months to a year off of prednisone, that patient will have recurrent sarcoid less than 5% of the time. So once you've resolved, and resolved means no signs of activity for 6 months to a year after you've stopped therapy, once you resolve like that, you really, it's not 0 chance of it coming back, but it's low. It's like around 1 in 20. Yes? I'm sorry, why don't you call it? You have better eyes than I do.
Here, and then here.
Granulomas release cytokines. You haven't talked about the mechanism of fibrosis, and do you ever use methoxypyline or drugs to decrease inflammation?
The question was, do you use pitfalls, which is an anti-TNF agent, since the inflammation seems to be driven by what's going on in the granulomas and the epithelioid cells releasing cytokines. It is not entirely clear what it is that's orchestrating why some people go on for fibrosis and others have spontaneous resolution. I mean, that is an important question, which is why I'm excited about the combined gene expression test study that I told you about, to get some ideas of what exactly is this gene expression pattern during the initiation and development of granulomas, as opposed to going into a patient who's had granulomas God knows how long, and then you do a gene expression study. Petoxyphyllin has been reported, again in these poorly designed studies, to be of benefit in some patients with sarcoidosis. The German groups have reported it being effective. I've not ever seen it to be that effective. I will use it in patients who predominantly have fatigue, because I rationalize that maybe their fatigue is due to TNF, and I don't want to put them through anything worse than petoxyphyllin, which is, except for nausea and GI side effects, is a pretty darn safe medication, although you got to take it 4 times a day and it's high doses. So again, there's some suggestions out there in Europe that it may have some effect. I've only limited its use in patients with fatigue. Yes?
Since the cardiac manifestation can be so devastating, do you recommend PET scanning on anyone diagnosed with non-cardiac sarcoidosis?
I think that at this present time, with costs being of concern and difficulties with insurance, we cannot recommend routine PET scanning. Should PET scanning become approved and should costs be managed, I would think that PET scanning would be done at every patient with sarcoidosis to, quote, stage them. Now remember, stage. We talk about stage 1, 2, 3, 4. That's the chest x-ray appearance. It's not the disease. So residents, please don't write patient admitted with stage 4 sarcoidosis. The patient was admitted with sarcoidosis, they have a stage 4 chest x-ray. Their disease is in stage 4. Likewise, telling a patient they have stage 1 disease and they walk out the door and drop dead from cardiac sarcoid doesn't give them any peace. So staging makes no sense in sarcoidosis. It's the x-ray appearance that we stage. I think true staging will occur when we find out which organs are involved and to what extent. And I think PET scanning holds a great promise in that. Right now it's just too costly and it's not routinely done. But it's amazing how much other disease is present. So for example, we used to think that bones involvement occurred in only 15% of patients. And I have to tell you that when we do PET scanning, I see a lot of osteosarcoid. And it's asymptomatic. It's really quite amazing how multi-system this disease really is. And it kind of makes sense. Why would the granulomas only go in one place? In support of that, while 5% of patients have clinically apparent cardiac sarcoid, at autopsy 25% have granulomas in their heart, while 5% of sarcoid has clinically apparent neurosarcoidosis, at autopsy 25% have granulomas in their CNS. So we're missing a ton of it. PET scanning seems to be pretty good at picking it up.
Last question, Dr. Foltz.
So in the patients with sarcoid who are being appropriately treated for one of the 5 indications, are combining steroids, what's your favorite thing?
So for steroid sparing, if it's skin manifestations and joints, I like using pentamidine. What is it? Plaquenil, thank you. Hydroxychloroquine. I was trying to avoid using the drug name so I wouldn't get in trouble. Hydroxychloroquine.
You're still going to get in trouble.
400 milligrams a day for skin, hypercalcemia, joints. Non-neuromethotrexate, and I usually start Imuran at the same time I start prednisone for neurosarcoid. Because you just need to get on top of things, and I know it's going to be a chronic course. So then Imuran. I've not seen much good with cyclosporin. Dave Moeller reports of using other immunosuppressives, but again, it's all anecdotal.
Well, Mike, thank you very much for this presentation. We develop a tradition here that people who don't do well get it back.
A Louisville slugger.
So you get a Louisville slugger that says, Michael-Iannuzzi U of L visiting professor of Pedigo lecture, November 4, 2010.
Wow, thank you.
Thank you, gentlemen. Thank you all.